All right, can you hear my audio now?
Yeah, I can.
Okay, I need to hang up. All right, can you still hear me?
Yep, still can hear you.
Oh, this is weird. Okay, cool. I'm gonna take off my webcam.
Okay.
Just gotta figure out where it's plugged in. It's weird because I can hear you through my headset, but I'm talking through my computer, I think. I don't.
All that fun stuff.
And I'll share my screen just to make sure we can see everything.
Cool.
All right, can you see it?
I can, yep.
Okay, I'm just gonna forward to a video to see if it plays. Okay.
Okay.
Okay, just gonna find where it's at. Can you hear it?
Yeah, I can.
Okay, good. Okay, cool.
Perfect. We'll get started pretty soon here. Do you see my face on your screen, Beth?
I do.
Okay. I will make sure that gets turned off prior to the presentation, but just so that everyone can see my face while I'm presenting to you.
Great.
Presenting you, I guess. All right, it's officially noon, so I feel like we can get started. My name is Lindsay Schultz. I'm a program associate here at the Iowa Cancer Consortium and leading the capacity building series with the Iowa Cancer Consortium. Today we have Beth Turner with us, who will be presenting on tobacco, more than a public health issue. Ms. Turner is a graduate of the University of Iowa with a Master of Arts degree in Health and Sports Studies, emphasis in health promotion. In February of 2013, Ms. Turner joined the community partnership team with the American Lung Association and now serves as the senior manager of tobacco use prevention and control. Ms. Turner has extensive experience in tobacco policy systems change, creating and cultivating community partnerships, and promoting and delivering cessation services and resources. Ms. Turner has assisted numerous local governments, workplaces, communities, multi-unit housing, property development, implement and enforce tobacco-free policies. Ms. Turner is a trained Freedom from Smoking, Teens Against Tobacco Use, and Not on Tobacco facilitator. Ms. Turner has completed One Iowa's Safe Zone designation program and the Racial Equity Institute's Racial Equity Phase 1 workshop. Thank you for being here today, Beth, and feel free to go ahead and take over.
Perfect. Thanks so much, Lindsay. Can you hear me okay?
Yep.
Okay, perfect. So like Lindsay said, my name is Beth, and I am the Senior Manager of Tobacco Control and Lung Health at the American Lung Association here in Iowa. So we are actually located
Beth, I think you went out.
Can you hear me still?
Okay, now I can.
Okay, thank you. I'm here as part of the Cancer Consortium's Capacity Building Series. Really,
Beth, I think you might have went out again.
tobacco and how often marginalized populations experience a higher burden from tobacco use. And this is really extremely relevant for our work in public health and really is a priority goal of the recently updated.
Hey, Beth, I think you might be having some technical difficulties. Your video or your mic keeps going in and out.
Okay, hang on one second. Let me see if I can switch it real quick.
Okay.
Can you hear me okay, Lindsay?
Yeah, I can now.
Okay, perfect. I just switched off my headset, so hopefully we won't have that happen anymore.
Perfect.
Perfect. All right, so I'll kind of touch base a little bit since I was cutting out a little bit, but really I'm here today just to discuss a little bit more about the landscape of tobacco and how we often see marginalized populations experience a higher burden from this use, and really relevant to our work and really timely with the update of the cancer plan and how this can really be integrated into public health as a whole. And so really for our objectives today, three kind of big ones that we're looking at here is really learning the overall impact of tobacco use in the US and in Iowa specifically, really understanding and identifying disparities that exist and really continue to persist in specific communities, and also learning some best practices to eliminate these disparities and really help individuals quit and move the needle in tobacco control as a whole. So just starting off with a little bit of background, for our organization, we work on what's called a community partnership grant, which is funded by the Iowa Department of Public Health, Division of Prevention and Control. And we really got this grant work started in 2003, and we had a 4-county service area to start. And now in 2018, we continue this work and have expanded to 8 counties in central Iowa. So you'll see our counties listed there that we provide direct services to. And with these partnerships, they also exist throughout the state. So there's a community partnership that is in every state and every county here in Iowa. And we work off of the best practices from the CDC. So really focusing on 3 goal areas for tobacco prevention and control, being to reduce exposure to secondhand smoke, preventing youth initiation of tobacco use, promoting cessation in the community, and identifying and eliminating tobacco-related disparities. So this is something that our organization has been focusing on within the last few years, a little more thoughtfully, and this is kind of what led to some of our work that I'll talk about later on here. And so really just starting about the burden of tobacco overall, I really don't think this first statement will surprise anyone to know that tobacco use is the single most preventable cause of death and disease. So much progress has been made over the last few decades but we're really looking at a preventable cause and a public health issue that impacts numerous individuals. And cigarette smoking itself is responsible for 480,000 deaths per year in the US. And this also includes more than 41,000 deaths from secondhand smoke exposure. So really thinking about tobacco use impacting more than just the tobacco user is really important, and it's a significant health issue and public health issue. And really we often think of the independent financial burden with tobacco use, but we really also must think about bringing attention and awareness to the billions, and that's with a B, that we spend as a country in adult medical care due to smoking. So really nearly $170 billion are spent every year in adult medical care. This is significant financial impact really to both the individual and the US for preventable negative health outcomes. And really when we even think about this beyond, direct healthcare costs, the dollars that are really lost from productivity alone, thinking of in the workplace, can add up to $151 billion. So really this number doesn't even include smoking-caused disability, sick days, or productivity declines. So really when it comes to tobacco use, the financial burden is huge, and it extends beyond the individual and really extends to a community as a whole with that burden. And looking at the health impacts of tobacco, again, I don't think any of this is going to surprise anyone, but I've listed here just some of the harms and diseases caused from smoking. And you may see kind of the ones we've heard about for a long time with cancer, heart disease, stroke, lung disease, but there's also a lot of research coming out, and even with the newest Surgeon General report, the link with diabetes and tobacco use. So really thinking expanding beyond kind of the normal things that we may think of when we associate with tobacco use. And looking at specifically in Iowa, we really see a lot of similarities when it comes to the dollars spent and the use rates. So 5,100 adults in Iowa die each year from their own smoking. And when we're looking at adult healthcare expenses and medical expenses, we see $1.28 billion spent yearly in direct medical care. And one thing you might notice here is there was a little more of a gap when we looked at the US in regards to productivity losses and medical care, but you'll see here in Iowa that they're actually pretty close to one another when we look at those numbers. So 1.21 billion is spent in productivity losses in Iowa. But when we look at the next slide, when we compare the rates of Iowa nationally, it may not surprise us that these numbers are so close together. And really this last piece puts into perspective the marketing and investment the tobacco industry places to retain and recruit customers. So the tobacco industry itself spends $96.8 million annually just in the state of Iowa for marketing. So I think that number's huge when we look at that money that is just spent in Iowa for marketing, and we compare that to the tobacco prevention funding we have in Iowa, which is about $4.1 million. That tobacco prevention funding is really just a drop in the bucket when it's compared to what the tobacco industry puts into Iowa. So I think that statistic in itself is really staggering for us to think about when we're thinking about how to combat this preventable cause of death and disease. So like I said, looking at Iowa versus national adult smoking rates, here you'll see rates from adult smoking from 2015 and 2016. And you'll see Iowa is listed in the blue, and then in the red is the national rates for smoking. And as you can see, we've really made significant progress throughout these last couple years listed here. But really you see that we still are higher than the national average in Iowa. In 2016, we closed this gap a little bit, but we still have a lot of work to do. And so maybe we can assume that some of those productivity costs being about the same as healthcare is maybe because we have a slightly higher rate than the national average. So really kind of diving in a little bit more about disparities in tobacco. So really, in order to improve the health in America, we really must find and treat tobacco use and tobacco-related diseases where are they most prevalent. As we continue really to see these rates continue to decline, we're left with the most impacted and affected by tobacco. So we've seen this great progress, especially, throughout the years where we're making strides in reducing tobacco use, but we often have these highly impacted populations where that's not the case. And in 2016, some public health organizations collaborated together to produce the Achieving Health Equity in Tobacco Control, and this was a statement that they made. So they believe that further efforts in tobacco control should recognize and give priority to the well-understood fact that smoking and tobacco use, and therefore disease, affects certain specific populations within the United States differently, with some suffering disproportionately from the tobacco epidemic. So I think this is huge to think about, and kind of as we analyze maybe some of the reasons and kind of analyze how these disparities exist, to keep that in mind. So like I said, we have significantly reduced the number of individuals who smoke, which really is a cause for celebration, and we should celebrate the successes that we've had, but still acknowledge that the work we have to do is ongoing. Also, now that over half of the US population are protected by laws banning smoking in public places, and in Iowa, we are really fortunate that we're coming up on actually the 10th anniversary of the Smoke-Free Air Act. So this July 1st, the Smoke-Free Air Act will have been in effect for 10 years, which really is crazy to think about, that it seems like it's been maybe longer than 10 years. And a lot of youth that are alive today really don't remember the time when smoking was allowed indoors, or we had to ask for non-smoking or smoking sections at restaurants. So we as a state are very fortunate to be one of the states protected, but there are so many more states that don't have this protection, and really looking to advance the state laws in those areas. But with that strength in our Smoke-Free Air Act, we also have to recognize the loopholes that exist. So we think about places such as federal veteran facilities. So they're able to have, if you've heard the terminology of smoking shacks, on their grounds that individuals can go into, and it's an enclosed area that people can smoke in. Long-term care facilities have a loophole, and then tribal and gaming establishments, so casinos, are also exempt from the Smoke-Free Air Act. So we have to recognize those as well. And here you can see just a timeline. Recently in 2014, it was the 50th anniversary of the first Surgeon General's report on smoking and health. So 50 years ago, we came out with the first kind of data that said we know smoking is harmful. So really looking at gaps in tobacco control. So with the progress that we've made, there have been populations that have been left behind. We see marginalized populations disproportionately impacted by tobacco, with higher use rates, disease, some having no insurance coverage, and low rates of successful quit attempts. So there's also a long and strong documented history of the tobacco industries targeting these populations. So a couple of groups that have been noted here are low-income communities, racial and ethnic minorities, the LGBTQ population, and individuals with mental illness. So like I said, these are really just to name a few, and there can certainly be more individuals that are grouped within these, but we have so much information, and I'll even pull in some images later that really speak to these target markets by the tobacco industry. One group listed could really be an hour webinar itself, or even more. So I'm just going to focus on a few of these groups and kind of dive a little bit deeper into why we may see some of these disparities that exist. So really looking at the data, what does it say? What does it look like? So when we look at the rate data, we can automatically see population groups impacted at higher rates. This graph is specific to persist data pulled from the state of Iowa specifically. So this is Iowa specific. All adult groups are seen on the far right. And as you can see immediately, probably the first one that jumps out to a lot of us is the Native American population. And as you can see, the extremely higher youth rates than all other races and ethnicities. And you can even see throughout the years, it's actually gone the opposite direction. It's increased, which is concerning. And one thought with this may be that tobacco use is highly embedded into the Native American culture. And really throughout the years, this has morphed into commercial tobacco being integrated and becoming utilized. So, you know, with the cultural background of tobacco use, we've seen commercial tobacco make its way in. And many campaigns, there's been a lot of work in Minnesota have evolved targeting keeping tobacco sacred in tobacco control. So you may have heard or seen some programs that currently exist about the sacred nature of tobacco and not commercial tobacco, and also being mindful of sacred tobacco use in policy systems change. And next I'm gonna talk a little bit about the African American population specifically. So we'll kind of take note here. There isn't as significant difference in Black versus white here listed as the graph states, as there are with the Native American population. So that's something I want us to keep in the back of our mind when we dive a little deeper into these next few slides. So really looking at the impact on African Americans specifically. When we look at this data, we see that secondhand smoke exposure is extremely high for youth in the African American households. So really what the data is saying is that nearly 70% of children were exposed to secondhand smoke in the home. And we all know the impact of secondhand smoke exposure, and it's been well documented. So this in itself is really concerning, even thinking beyond just the smoker potentially in the house and thinking to secondhand smoke exposure, third-hand smoke exposure, and how those can have negative health outcomes and lead to kind of those disparities we've been seeing and the financial disparities as well. Also, when we're looking at youth specifically, the prevalence of youth cigar use is higher than that of cigarette use for African Americans and is higher than any other racial and ethnic groups. And you know, this could be looked at as background to marketing. I know that with Black and Milds, there's a lot of marketing surrounding the African American community and also targeted marketing as well. Some of this could also be linked to the increase in flavored tobacco products used by both youth and also the high rates of menthol use in African American communities. And really, we're going to speak a lot more to menthol here later, but really focusing on that small difference in the two communities. And additionally, many African American smokers begin at an older age and smoke fewer cigarettes than compared to white population. So really looking at where these disparities exist. So recent studies have also shown that African American smokers have a high motivation to quit. They want to quit and even make more attempts than white smokers. So this is good, right? Well, when we kind of dive into this deeper, we see a high motivation to quit and an increase in the quit attempts, but really the rate of successful attempts is extremely low. So we see individuals wanting to quit, but really not successfully doing so. So among individuals who made a quit attempt in the past year, only 3.3% of African Americans remained abstinent after 6 months, compared to 6% of whites. So putting this into perspective, almost half of the individuals who tried quitting were successful. So we're seeing a longer lifetime of smokers due to the fact that it's really hard to quit and people aren't quitting successfully. And there may be an association in this statistic with the unsuccessful quit attempts with the high nicotine dependence itself. There's been some high cotinine levels associated and the high use of menthol tobacco products in the African American population. With these factors and really the longer smoking life, we can see potentially why some of these disparities exist, and really the fact that African American smokers are potentially more likely to die from smoking-related diseases than whites. When looking at the LGBTQ community in Iowa, so switching population groups a bit to talk about the rates, we see rates that are nearly double compared to the heterosexual population in Iowa. This data specifically on the screen is for persist data again, and you will note that only the LGBT populations are represented. So the transgender population was eliminated due to the low data set. And you'll also know here that rates are highest among the younger adults and women in the LGBT community. So that's something to take note, that also within the community, there are some disparities that exist with different groups. So I think that's something to keep in mind when we talk a little bit further. And when looking at youth specifically with this data on the screen currently you'll see is from the Youth Risk Behavior Surveillance System. So in Iowa, we actually do not ask for sexual orientation, gender identity data on our Iowa Youth Survey. So we'll talk a little bit about this more in the next slide. But really, as in the previous slide, you can see the disproportionate use rates in the GLB community in every category except smokeless tobacco. So that is something to note, that it actually is lower with smokeless tobacco, but almost over 2 times higher with current frequent cigarette use, and then the green is current cigarette use. So you can see the high difference between heterosexual youth and then gay, lesbian, and bisexual youth when it comes to cigarette use. So really what is important to know here, that there's a significant lack of data for most health behaviors, really including tobacco use in the LGBTQ community. In Iowa, it wasn't even until 2012 that we began asking about just sexual orientation information in the persist data collection. And this wasn't even required as part of the core required questionnaire. Really in 2014 is when we began to see more data being collected. The CDC actually created what we call SOGI, but sexual orientation, gender identity questions, to be utilized in persist. So really without the data, it's really hard to create change in policy systems change and programming, because data really drives a lot of our efforts and really shows that there's the need to address this. And really, it creates problems to understanding the health risks and disparities if it's impossible to compare with other groups. And really, when it comes to grant funding, it can minimize these disparities that exist because simply that we don't have the data. And really, this creates a huge missed opportunity for programming and policies to address these tobacco disparities. And again, along with the higher use rates, we see again secondhand smoke being a common theme of higher exposure. So LGBT individuals are 1.7 to 2.4 times more likely to be exposed to secondhand smoke in the home. Lastly, I think these last couple stats are going to surprise a lot of people potentially, that when looking at the money spent on tobacco and investment in tobacco, LGBTQ individuals spend an estimated $7.9 billion annually on cigarettes, and that this is 65 times more money than the money that is put back into LGBTQ issues. So I think that stat in itself stands out a lot, that the contribution made to the tobacco industry, but in turn, how much more that is than, money that is put toward campaigns or programming or events that contribute to fighting LGBTQ equality. So kind of the last specific population I'm just going to touch base on really quickly is looking at the mental and behavioral health population. So when we look at individuals in the mental health and behavioral health population, we really see high rates of use and high rates of use of product when compared to the general population. So the first stat you'll see is that more than 1 in 3 individuals with a mental illness smoke cigarettes compared to about 1 in 5 with no mental illness. So this is really concerning in itself when we see these higher use of rates in these specific populations. And when we look at the use of tobacco products, about 3 of every 10 cigarettes smoked by adults are smoked by individuals with mental illness. So really not only are rates higher, but more cigarettes are being smoked. We really then see high rates of nicotine dependence, but still this group has a similar motivation to quit. So there's often the common misconception that individuals that have a mental health or behavioral health diagnoses cannot quit successfully. And that's far from the truth. We see high rates of success with appropriate intervention and also a high motivation to quit that really reflects the general population. We really still have a long way to go treating the dependence of tobacco in this population. Many times, especially in mental and behavioral health, tobacco is seen as the lesser of evils. So maybe other behaviors need to be treated before tobacco dependence is treated. And really a lot of research has shown the increased likelihood for sobriety and recovery if individuals quit everything at the same time. A lot of that research shows about 25% higher success rates if those are all quit at the same time. So really working to educate communities in the ability for individuals to quit, and also appropriate intervention that will make the quitting attempts successful. So this slide really probably angers a lot of people, in which it should, and it speaks to the well-documented history of the tobacco industry when it comes to targeting marginalized populations. So this quote is specific from a tobacco executive when asked why he didn't smoke. So the quote directly is, "We don't smoke that blank, we just sell it. We reserve the right to smoke for the young, poor, the Black, and the stupid." So I think in itself, this just goes to show how much money has been spent by the industry over really decades to attract populations and bring them to be their customers, and that they're really good at marketing, and they provided certain tactics and spoke to certain populations to result in potentially higher use rates. So I think this quote just serves as a catalyst to be able to address these disparities so they don't continue to persist in these groups. And really, it points to the social issues and social justice issues in tobacco control. And we're going to take this time now to really look further at the targeted marketing and the impact on certain communities that it has. So I'm hoping this will play and you will be able to hear it all.
Big Tobacco must love diversity. They love it so much that here they advertise up to 10 times more in Black neighborhoods than in other neighborhoods. 10 times. How is that okay? Big Tobacco is really trying to make friends with Black folks. I see you. So much that in the past, Big Tobacco called us a market priority. It's not a coincidence. It's profile. Don't let it go unseen. Enlist at thetruth.com. Be the generation that ends smoking.
So that was a recent campaign throughout the year of truth that has really been pointing to a kind of a common theme that we've had focusing on the tobacco industry, and that, you know, there are tactics that are taken to appeal to certain communities, and just really bringing that to light and bringing the issues to light to really gather support from the community and public health to be having appropriate interventions and education to tackle these issues. So again, the Truth campaign has a few of those videos out and have been using the hashtag Stop Profiling just to bring awareness to this issue. And another one that is specific to the LGBTQ community that some people are aware of, some are unaware of, is Project Scum. So this was initiated in 1995, and Project Scum is the acronym for Subculture Urban Marketing. So really, when it's spelled out, it sounds really fancy, but I don't think there's a coincidence that it was, it's called Scum. So we know that this project was very prevalent in kind of the early years of the 90s and was led by R.J. Reynolds. And this project targeted gay men in the Castro area and homeless living in the Tenderloin. So really was focused specifically in the San Francisco area. And really this project led to infiltration into LGBTQ populations and publications and other advertising venues. And something to think about is this timeline of the 1995. I don't think is any coincidence. Right kind of in this era was the height of the AIDS epidemic, and really kind of targeting a population when it was most vulnerable. Again, you'll see through some of the ads that I show, there really has been this conscientious targeting and language by the tobacco industry to attract new generations and new smokers. So again, you'll see things like take pride in your flavor, I choose. So really pulling out pride as the language and motivating factor to attract the LGBTQ population. So thinking back to, this was in the 90s, and there was even saturation in a lot of LGBT population magazines that shows these ads surfacing well before they've been saturating other markets. So I think that's important to look at when we look at some of these ads and to think about. So really the target marketing, we can really see the impact of the tobacco industry and the decades of targeting when we break down the areas and look at it a little further. Tobacco companies use price promotions like discounts, multi-pack coupons, so 2 for 1, which research shows are most often used by African Americans and other minority groups, also women and young people, to increase sales. So providing these coupons specifically to markets that they know will utilize them is another marketing tactic. The tobacco industry also knows this and uses it to keep customers. Really, it's no coincidence when we see these promotions saturate certain markets and we actually talk to where these markets are located. This will probably also make people mad as well when we see this. Areas with large racial ethnic minority populations tend to have more tobacco retailers located within them. So you think about if there's more advertising, there's more markets involved, it really can contribute to the greater tobacco advertising exposure across the lifespan. So youth, adults, older adults, all have a high exposure to those ads. Also, really, menthol tobacco products are given more shelf space in retail outlets within African American and other minority groups. So menthol is hugely saturated in minority groups and populations. And again, we'll talk more about this later. I have one more video, so hopefully everyone can hear it.
I started smoking really young. I've been a smoker since I was 14 years old, and I'm 40 now. I come from a really small town, but once I went to college, well, there were other gay people there, and they all smoked. By the time I was smart enough to realize what was going on, well, I was already addicted. It's even damaged the relationship between my non-smoking partner and I.
In America right now, 1 in 5 people are smoking. In the lesbian, gay, bisexual, and transgender communities, we have smoking rates that are almost 70% higher than the general population. And why such extremely high smoking rates? In the LGBT communities, the stigma that we experience can nudge anybody towards unhealthy behaviors.
Coming out and not knowing what my life was going to be like, you know, I smoked a pack of cigarettes every day.
It's easy to fall into the trap of smoking. So many LGBT people are already so stressed out about coming out or just living their daily lives.
You experience the isolation from your family, from school members. You're looking for social acceptance.
Add to that the additional stressors of being discriminated against or having your rights denied because of who you are and who you love.
And I think that's what's been capitalized off of. You're not normal. Here, have a way to relieve that stress.
We're targeted by the tobacco industry because we're a very easy population to sell to, and we pay them back in decades and decades and decades of handsome profits to their bottom line.
Because it looks like they care about us, because they're sponsoring our events and they're running ads in our magazines. And it's a lie.
Smoking is everywhere. It's part of the fabric of our communities. It's also the #1 preventable health problem that we can steer clear of.
We all have a role to play in being activated for health justice.
And it's going to take a lot of work at a lot of different levels. First step is we need to help the LGBT communities realize we have this huge smoking disparity.
And knowledge can kind of strike the match, but in order to keep the flame going, there has to be support mechanisms within the community.
Part of this solution is going to be our own community members standing up and demanding to be included in health programs that are working on tobacco.
As a smoker, tobacco makes a lot of the decisions for me. I don't want to have to feel like I have to go smoke because smoking has that control. I want to be able to say, I can do what I want.
I have now been smoke-free for about 15 years. Quitting smoking was incredibly liberating. It's time to make a change and save our community and save our own lives.
I've spent 26 years listening to nicotine instead of myself. Yeah, it's time to quit.
So as that video really spoke to, and we kind of saw with the last video, we're starting to see more resources and videos bringing light to the injustices in regards to tobacco control. So the Truth Initiative has been doing a lot of work on bringing this to the forefront and really just bringing it to people's minds about how the tobacco industry has targeted these communities and have the impact of that targeting throughout the years and potentially why we're seeing some of those higher use rates. You know, as was spoken to, the high stigma that's associated can lead to those unhealthy behaviors is a huge thing to think about. And as I said, kind of bringing some of the media to light. So these ads are from what's called Trinkets and Trash, which anyone can access. It's a program through Rutgers University. So this resource has tons and tons of tobacco promos, tobacco ads throughout the years. So you could go back probably to even the 80s or beyond to find tobacco advertisings that were prevalent. And these ads are specific to targeting towards the LGBTQ community. So you can see there are an array of tobacco ads, and the themes really pop out of pride and freedom utilized to attract this community and really portray an ally relationship. So again, they were one of the first programs and really markets to begin advertising in publications targeted towards the LGBT community. So it makes sense why it may feel like a friend or ally relationship. And a lot of the ads in the earlier years were inconspicuously targeted. So many of them had two men and a woman or vice versa, that it wasn't immediately prevalent who they were targeting, but those markets could identify that target. So again, we see the freedom to speak, to choose to marry, get lucky, taking pride in your flavor. There's even the incorporation of drag within that, having the e-cigarettes utilized there. And then here we see some targeted marketing towards the African American community. Noticing a majority of these ads are for menthol. When I was looking through for these ads, I honestly could barely find any ads that were not actually advertising menthol. Newport is a huge advertiser for the African American community. I found so many ads that were targeted. A lot of this, it looks like you can have your cake and eat it too. Again, here are the coupons you asked for. So the price discounts, price promotions. You can see one with younger women in it in a club scene. It appears to be the integration of jazz, and even looking at the newer evolution of tobacco products with the blue, and kind of a lot of research has, coined the term like urban targeting with these markets. So kind of looking here, and in a big overview, we talked a lot about the use of menthol and how it's higher in the younger population, also a lot of disparity in minority populations. So you can see here that in 2013, the FDA released a report finding that menthol cigarettes led to an increased smoking initiation among youth, young adults, greater addiction, and decreased success in quitting, which I think is super important to think about. So we have these higher use rates of the flavors, and especially menthol, in specific communities. And there's research telling us that this makes it harder for people to quit. So again, prolongs those individuals using tobacco. And another thing that menthol does is reduces the harshness of tobacco. It really makes the sense that a younger generation may appeal to flavored and menthol specifically. And again, it keeps smokers hooked for life because it reduces that harshness. So again, appeals to maybe a younger, newer generation of smokers. When looking specifically at the integration of menthol, again, highly marketed, like we saw with those ads. I think almost every one of the ads was a menthol ad targeted towards the African American community, and marketing in publications and venues whose target audiences are Black. Nearly 9 in 10 African American smokers aged 12 and older use menthol cigarettes. So really looking at these youth rates broken down even beyond different ethnicities and races, we see huge discrepancies, and 95% of teens who are current smokers smoke menthol in the African American community. So again, we can maybe assume that these are from the high targeted menthol ads, the high saturation of marketing, and the high number of retailers. And even when we talked about previously, the shelf space is given priority to menthol tobacco products. So it makes sense why we can see these things continue to exist. So when we look at where tobacco retailers are at, we can even see the disparities here, and this is specific to the Des Moines area. So this is a screenshot from Counter Tools point of sale mapper. So anyone can access this website. Again, Counter Tools is the partner that has this available, and the state of Iowa actually has a partnership with them working on specific retailer density zoning information that we can utilize as communities. So what I did here is I broke down the retailers by zip code. Again, we could go to the entire state, but it would be very overwhelming to see that on a screen. So you'll see here that if you're familiar with the Des Moines area, it may kind of make sense when we look at these retailers. So what we notice is the number that's circled is the number of tobacco retailers within that zip code. And you can see that the zip codes are defined by the orange, yellowish areas. So if we look in downtown Des Moines, and we look at the south side of Des Moines, you can see that just in that zip code, there are 42 tobacco retailers, which is huge. You can see that even the zip code isn't as large as some of the other zip codes located. And then you go just, over to maybe more of the Urbandale, Windsor Heights area, we see 11, 27, so significantly lower in what you could assume to be more higher income population zip codes. So again, we see the retailers saturating the areas of lower income and high minority population group areas. So I would say that it would be really interesting for everyone to utilize this data and really see where the retailers are at, how many retailers are in these communities, and really thinking about how we can tackle that and how we can work towards reducing these rates when the advertising exposure is huge in these populations and especially in certain areas of our state. So again, we've talked to this a little bit throughout the presentation, but there are 10 times more tobacco ads in Black neighborhoods than in any other neighborhood. So really that targeting towards certain racial groups and minorities. So really we've talked about how these rates exist, the disproportionate rates of certain groups, and really how we continue to see the tobacco industry targeting these groups. So really, how do we go from here, now that we recognize these disparities, to bring change into these rates and reduce these rates overall as a community? So really, we as public health professionals have the obligation to tackle these disparities and really reduce these rates across. These next few slides, I'm going to specifically talk about some of our work that we've been doing in decreasing tobacco use within the LGBTQ population as well as other populations. So how this work is started with our grant a few years ago, that we really wanted to dive deeper into some of the reasons behind the higher tobacco use rates in the LGBTQ population. And what we set out to do is really to just meet people. Our first goal was not to come in to any community and pretended like we had the answer or pretended that we knew everything. So we really wanted to learn more and then just really invite people to the table to have an open discussion. So really what we did first was we had a coalition meeting or community conversation, what you would like to call, in 2016, and invited a broad array of community members, organizations that worked with the LGBTQ community, and invited them to just have a facilitated discussion on why we thought these rates were higher. In our area specifically, what were some of the repercussions or negative impacts that would happen if we initiated policy change, or if we reduced these rates? What were things people should be mindful of? What were cessation efforts or promotions that people would appeal to? And so this was really a catalyst that set us to develop a 10-year vision and really a 10-year action plan for our work. We realized that this wasn't something that was going to happen overnight, and really is really going to be just a really cumulative effect of efforts throughout years. And so just kind of some of the things that we started off by doing was really being visible in the community. So attending the Governor's Conference on LGBTQ and Youth. The Iowa Cancer Consortium has partnered with us in various efforts in conferences, attending Prides. You'll see we made buttons for Pride that really just focused on, again, raising awareness and celebrating people that quit. And we developed the Kiss Me, I Quit buttons, thinking that, a lot of people that have recently quit would take it. And we found that people actually took those that they wanted to quit, and it would come about and they put it in their pocket and save it for later. So that was really something that we thought was unique and really different. And kind of with these efforts, we reconvened our tobacco community conversation group in 2017 at the end of the year, really to just update and progress, because we really were going around trying to find advertising or media that would really speak and resonate with individuals. We didn't want to just produce something and send it out into the community. We wanted the community to have an input on what we produced and really own the video itself. And so what we did is we brought together and we decided that we wanted to create a storyteller's video series about how individuals quit tobacco, how the industry is prevalent in their community, and really just put humanity and a face to tobacco control. And then you'll see on the left, we are actually creating a group disparity video in addition to the LGBTQ video, really highlighting kind of this entire conversation we had and just bringing awareness to the issue. And this should actually be hopefully a good draft by the end of this fiscal year. So I'm sure we'll be sharing that with you. And really just thinking about what we can do as public health professionals. I think one of the best approaches is really finding the champions and the leaders, which is really true for any community or coalitions that we're looking at starting, really finding the people that individuals go to really cultivate change. Another huge thing I think is important is being a listener. We can often come in and think that with the background and the data, we know what will work, or we have a great idea and bring it to the community without really involving individuals that are affected. So really just going and being a listener in the community. And I think that also produces respect within the community. If you're coming as a listener and have no asks, no wants of the group, I think it just really goes to show the investment that you have in that community. And also on the flip side, just being an observer, immersing yourself in events, asking questions, diving deeper into all the elements of what you're thinking about. Getting to know what's important to communities, getting to know where people are. So just continually learning and being visible. And really one thing that I think sometimes is missed with this work is even thinking about internal policies in your organization and your office. So maybe thinking if you're specifically working with the LGBT community, it may be really good to evaluate your internal policies on diversity and making sure that they're reflecting and supporting updated policies in regards to celebrating diversity. So I think that's something that can be lost as well. So making sure your organization reflects the community and the support that you're going and working on. Another thing is just really thinking about empowering communities to advocate on their behalf. So it's one thing if an organization comes in and spreads awareness about these efforts. If the community is not behind the work, it's really not going to create that change. And so really bringing individuals to the table and empowering those individuals to be the voices for their community and just really start the fire of creating these policies and advocating for more cessation resources that are specific to their community. Really just facilitating the information of tobacco-related issues impacting the community. So really serving as a kind of a connector in the community, bringing the information you have about tobacco control and really finding who can be the voice in that community. How can you help them? How can you bring it further? Again, developing culturally appropriate resources to build the capacity and implement strategies for working with these populations, and promoting and maybe even developing, if it doesn't exist, cessation tools that are designed with specific audiences in mind. So I think really just thinking about overall, like I said, you could contribute an entire hour conversation talking about the background of disparities on certain population groups. But I think one thing to think about in public health is that we really can make an impact on these rates and really reduce them as a whole. And it's just bringing the awareness to these disparities, how they exist, that really we can cultivate the most change. And I think being mindful that, again, like a lot of things in public health, this won't happen overnight, and it's really a continued effort. But again, I think being the listener, being the observer, and really going to the community to find what they want and what they need creates a great relationship to gather trust and investment in the programs and in the work. So like I said, again, this is something that's been evolving in public health for quite some time, and we're starting to see some more momentum from programs, the FDA coming out with programs, the Truth Campaign, really to educate and bring to light these disparities that exist. So I guess I'll pause since there's just a couple minutes left. If Lindsay, anyone has questions or anything?
I don't see any in the question and answer box right now or in the webinar chat, but anyone can feel free to ask any questions. And I guess we can wait a second to see if anyone has a question.
Okay.
Otherwise, I can ask one of my questions, I suppose.
Sure.
So I was wondering, you talked a little bit about vaping and how those industries are still targeting the minority populations. Do you see, there's probably not much research on it at this point in time, but do you see those disparities existing still with the vaping products in these communities that people are targeting?
Yeah, I think as far as new tobacco products are concerned and the e-cigarette industry in general, the products tend to be slightly more expensive than traditional and combustible tobacco. So I think there's a targeted marketing, but may not be associated with the targeted marketing that we just saw. I think it's almost looking like, at least the ads that I have seen, seem to be targeting more maybe of a higher income community that may be not traditionally associated with higher combustible tobacco use rates. So it'll be interesting to see as these products evolve a little bit more. But if you kind of saw the couple blue ads I had, it seemed to be targeting a different population.
Any more questions? Doesn't look like it.
Perfect.
I have a Survey Monkey just to do an evaluation that I'm going to put in the chat box. If everyone would take that, I'll send it out to everyone too. But thank you again, Beth, for this super informative presentation. And we will continue to be working with you. So I can't wait to see where things go in all the work that you guys are doing. So
yeah, I am excited for our work together and finding our video with the Boost Grant funding.
yeah. All right. Well, thank you everyone for attending. I really appreciate it.
Thanks so much.